Good afternoon, morning, evening, depending on where you are in the world. Welcome to the Aged Care Industry Information Technology Council and Australian Digital Health Agency Forum. We will be going ahead in a minute or so, just giving people a chance to log in. Okay, well, we have a pretty tight schedule today, so I might kick off and we'll have people joining us as we go along. So welcome to the Advancing and Achieving Digital Maturity for Aged and Community Care Forum. The Australian Digital Health Agency has partnered with the Aged Care Industry Information Technology Council to deliver the National Awareness and Training Series promoting digital maturity in the sector. Today is the second of 3 events in this digital roadshow. At this stage, the Council acknowledges the traditional owners and the custodianship of the lands in which we meet. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contribution to Australians and global society. I'm here from Gadigal land, but we all are coming from different parts of the country, so we all pay our respects to their traditional owners. Just a little bit of housekeeping before we kick off. There are quite a few people joining this session today, so at this stage your microphones have been muted. If you have any questions during the event, please use the Q&A button at the bottom of your screen to post those into the Q&A panel, and we will forward those on to the relevant speakers or answer them via the Q&A panel if we can. The session is being recorded for future use, so it will be made available to you in the next coming days. If you have any technical issues during the event, please use the Q&A panel to raise those technical issues, and our wonderful Q&A team in the background will help sort them out as soon as possible. We do have quite a jam-packed agenda today, and it's some very exciting speakers to join us, so I won't spend too much time talking. Today's event will focus on advancing and achieving digital maturity for the aged and community care sector. We will hear on advancing research from Professor Len Gray, Dr. Claire Mason, and Ms. Anne Livingston. We'll also hear case studies on advancing and achieving best practice from Mr. Daniel Petman, Mr. Peter Newman, and Mr. John Sutherland from their relevant organisations. And we will also hear from the Australian Digital Health Agency on the current and future strategies the agency is undertaking to improve digital health literacy for both consumers and providers in Australia. Before we commence, I'd just like a brief introduction to the Aged Care Industry Information Technology Council. We have been formally established since 2007, but have been around for a lot longer than that in various forms. And we are an amalgamation of the ACSA and LASA, the two key peak bodies in aged care, who worked together in 2007 to form a separate organisation to represent them and the provider community in the use of technology in our sector. We do a couple of different things. We promote the analysis of our sector. We provide research-backed evidence, and our key goal is to improve the outcomes of our sector through the effective, efficient, and effective use of technology. Over the last few years, we've been doing some major research work, kicking off with our technology roadmap in 2017, which was a direct response to the government's roadmap for aged care, which we thought was lacking in the role of technology. So therefore, in 2017, in conjunction with Flinders University and via a number of consultations around the country, we developed what we call the version 1 technology roadmap for aged and community care in Australia. Following on from that, we then looked at the evidence based around the use of technology in aged care, and we came up with 2019 with a comprehensive report on the evidence base as of that date in the use of technology. In 2020, right in the thick of the COVID pandemic, we also published the capabilities in aged and community care readiness and evaluation of innovation and technology, or as we like to know it, the Care IT report, which looked at the current capabilities of the use of technology in aged care, both pre and to some degree during the pandemic, and came up with a number of recommendations around how that can be improved. Since then, we also did some work with the Digital Health CRC, looking at a national network of living labs for the aged and community care industry. As of yet, that hasn't been published, but has been used internally by both organisations to develop their strategy. And just end of last year, we did some work with the Australian Digital Health Agency looking at the use of clinical software in residential aged care in Australia. Again, unpublished, but we hope to have that available to you in the future. But again, being used widely by both the agency, the Federal Department of Health, and the council to help develop strategies going forward for aged care. Our next big project, and one which we look forward to engaging you all with, is Roadmap 2.0. So since 2017, we have found that the technology sector has significantly increased. We obviously had in the interim the pandemic, which demonstrated the need for connectivity and communications to be improved, and the Royal Commission, which also has a number of significant recommendations around the use of technology in aged care. So we will be working on over the next year our Roadmap 2.0, which was designed to build on the previous roadmap and provide a strategic roadmap for the sector to going forward, both at individual provider level, but also at government policy and regulatory levels. We do welcome you to engage with us going forward with Roadmap 2.0. It is a very exciting project. I think will provide a basis for the digitalization of the aged care sector in Australia, and for us to have a world leading role in becoming an advanced user of technology in aged care. And the important thing, of course, is when we look at the use of technology is to make sure it is based on research. So today's initial topic will be around advancing research. We have a number of great speakers who are world leaders in research in their relevant areas. And I'd like to kick off first with our very first speaker, who probably needs very little introduction, because if you've been involved in aged care or geriatric medicine in Australia for the last 3 or 4 decades, you would have heard of Professor Len Gray. Len is the professor in geriatric medicine at the University of Queensland. He's an experienced clinician, health manager, and research, and his current research interests relate to clinical informatics, decision support, quality measurement, and telehealth. His research team has been contracted by the Department of Health to develop new quality indicators for residential and home care. He also has a strong role in telehealth with the Centre for Online Health at the University of Queensland. And he is a board member and team leader within the InterRay International Research Collaboration, which has developed the world's most widely used assessment systems for aged care. So with no further ado, I hand over to Professor Len Gray.
Thank you, George, and thank you to all of you for inviting me along to speak for a few minutes. I've been offered 15 minutes to talk about the work that we are doing at the University of Queensland, which is now quite substantial and extends into quite an array of areas of clinical informatics, in particularly in acute care, but also in aged care. And today I'll just speak about a couple of elements of the work that we're doing in aged care that I think may be of interest. Firstly, I'd like to say something about data standardisation, because I think it's a really important and challenging issue in Australia at the moment. And then I'll speak briefly about the work we're doing in the project called Aged Care Data Compare to illustrate some of the development work that we're doing. So this is the kind of data element that one sees in software solutions in Australia. And it's an important concept. It's in aged care, is can the individual walk independently? And typically one might see a statement like this with a box which will have a checkbox. Now, if you look at that, you presumably think if there's an X there that this person can walk independently, but maybe the X means they can't, I'm not sure. But this is the dilemma one has when one sees an item like this. Now, if you saw that, you would not be sure whether the person walked independently or the box hadn't been filled in yet. So there's a problem here. I guess if you saw another item adjacent to it that says the person has 2 arms, you would be starting to worry about the integrity of the first item, because I think most individuals have 2 arms, and if that's not checked, it suggests the document hasn't been completed. And you'd get very worried if the third box was not completed, which says the person has a nose. We don't have many residents that don't have noses. So maybe a better configuration of the data would be to have a yes/no choice, and then you'd be fairly confident you understood that the box, the item had been scored. However, some individuals decide they're going to have an unsure box. I think and if that's checked, you would be wondering what was going on they clearly wouldn't know the resident if the person was said, if they didn't know whether the person walked independently. So probably not good to have unsure boxes. You probably should force decisions. So these are just illustrations of problems that are very common in both hospitals and residential aged care and other programs in Australia, where there are made-up items, particularly which don't have good psychometric properties. So what does a good data element look like? So there's quite a lot of features that need to be thought about. The first is it valid to the task? So I think we'd be pretty happy about the idea of independent mobility. Do different individuals score this similarly? So you have to develop a program of work to test inter-rater reliability. To what extent does it tell you about the extent of the problem? So a dichotomous scoring or a checkbox arrangement just tells you, it makes some sort of decision about whether the person's walking independently or not. So in that example I gave, if the person used a walking aid, would you consider that to be independent? If someone supervised them or walked alongside them, would that be independent? And so we don't know anything unless we've got some granularity. Is the data element compatible across the various settings in which people are cared for? And the answer to that in Australia generally is no. This kind of phenomenon is scored in a different way virtually in every setting, and even within settings. And is the data element designed in the context of a philosophy of collect once and use many times? And that of course is a big issue in terms of data efficiency. And finally, is it configured or presented in a way that it can be shared amongst organisations? There's a data transfer challenge, of course, but also can it be interpreted and understood between organisations? And does everybody know how to interpret the way the data is presented? So to develop a data element and get all of those characteristics kind of tidied up is actually essentially a year or two's work, and in many instances, many years' work to produce something that you get good, reliable psychometric properties across all of those parameters. So just let me turn back to the idea of person walking independently. So this is a really important phenomenon and a characteristic of a person, and there's a whole group of stakeholders are interested in this phenomenon, and this would include care providers who this will kind of tell them something about what the care and support is that they need. Does the person need an aid? So that at both an organisational and individual level would drive that set of care provisions. It also contributes to the calculation of falls risk in most falls risk screeners, and to pressure injury risk in most pressure injury screeners. And most case mix systems in long-term care will have an interest in this phenomenon, and there will be quality indicators about functional decline that depend on this. And finally, if a person is transferred, say, to hospital from our ACF or a home care program, this information will be important to transfer, to transmit. So there's at least 7 instances where this data element could be used to inform some kind of decision making. So there's obviously administrators, care providers, system administrators and the like all have an interest in whether this person can walk independently. So here's the environment that we live in Australia around mobility. And this is not comprehensive, but it gives you an illustration of where we're at. So in the provider world, we've got a whole mix of ways of describing mobility, from a simple example like the early checkbox approach, or other organisations use some kind of scaling device out of the literature, like the Barthel index or whatever. At least that has good psychometric properties. But every organisation, every software vendor seems to have a different array of measures of mobility. And even within the similar users of the same software, they have a pick list of the items. So they don't necessarily record the mobility problem the same way, even though they're using the same software solution. In the My Aged Care or the aged care program, there's a self-report version of mobility, and in the transition care program, the Barthel Index short version is used to record mobility. And there's probably various other places in the My Aged Care environment where mobility is recorded one way or another. The new case mix tool for residential care actually records mobility independence 3 times in the functional independent measure, in the DEMI, and in the Braden pressure injury risk scale. All use the same concept configured differently. So even in one tool set, there's 3 iterations of the independent mobility. And if you go to hospitals, you see a panoply of ways in which mobility is recorded. So is this an example of collect once, use many times that we are witnessing in Australia? Or perhaps we could suggest it's collect many times, use occasionally, that we're actually observing when we look at the way we're recording this information. So is there hope? Is there a way of getting forward? Of course there is. Oh, sorry, I want to say something about data burden. This is my back envelope kind of estimation of what data burden looks like. So if we assume that it takes 2 seconds to complete a data element like this independent mobility, and this was done 4 times per year for an individual, for 200,000 residents, it would generate about 444 hours of work, assuming somebody sat down and did nothing but data entry all day without any breaks. And adding all this up, if you use 7 different versions of walking independently, rather than 1 version, you'll require 84 FTE of registered nurses to record the information. And that basically works out at a minimum of about $7 million of wastage in data entry. If you used 1 element, you would be spending about 1.2, 1 version, 1.2 million, 7 versions, 8.4 million. So this is material waste. I guess it's a multi-billion-dollar program. People may not care, but at the coalface, I think people are very interested in data efficiency. So as you heard, I work with Indiri. Indiri has a very robust process for developing data elements. And here's the example of the walking item that's in the Indiri long-term care facility assessment. You can see that it's quite granular with 8 levels of recording. And on the right-hand side, a very extensive manual which describes how each of the elements, each of these data elements are scored. It actually still takes 2 seconds to complete. Even though it looks formidable, it still takes the same amount of time as the simple checkbox. Most of the time spent in recording information, of course, is understanding the resident and knowing what they do. The actual recording is opening up some software and checking a box, and that takes a couple of seconds. Of course, if we took 5 seconds per box, it would blow the cost out to much more than $7 or $8 million that I spoke about. So the Indiri walking item, not only it's built in exactly the same format into over 20 systems that span from early childhood to palliative care. And it's made use of in multiple ways. In other words, collected once and used multiple times, using it for ADL scaling, for multiple risk assessment tools, for care planning triggers, for quality indicators, and for case mix. Always using data element in 20 different systems. So this is an example of use once, collect once, use many times. So it is possible and it is done. So just the last few minutes, I'll talk about aged care data compare. Here's an example. One scenario that we're challenged with is older people going to emergency departments and understanding what their functional status was before they arrived. Another scenario in which data is critically important is where a clinical manager wants to understand their caseload, wants to understand the quality of care they're delivering, And they seem to have different types of residents in each of their facilities, and they struggle to make direct comparisons. So there's a risk adjustment kind of problem here. So these are the two kind of scenarios that we are working on with this aged care data compare project. And we're now 2 years into what we hope is a 4-year program. We've worked up a data inventory for use for calculation of quality indicators. We've built a suite of data exchange tools using HL7 Fire infrastructure and technology. And we've selected a battery of quality indicators, some 25 indicators that can be calculated from the data set. And we are currently building up a data hub to enable benchmarking to occur with the data that's been collected, will be collected. And this is going to be operational in this quarter. We're nearly there. And we're using the Inter-Eye long-term care facility as a proxy data standard. And I won't go through that, but I've already talked a bit about Inter-Eye. So we've included in our battery of quality indicators the current mandated quality indicators, but also another 20 that can be calculated from the data set that we've built to calculate QIs. So going forward, our aims are to apply these tool sets and know-how to a real-world situation and to demonstrate the effectiveness and efficiency of these solutions. So we're developing a proposal with a large provider and with a software company to build a data collection and export capability, and to set up the processes to retrieve the data and to calculate quality indicators and set up a benchmarking process. We have quite a number of documents. There's our website's listed on the bottom left-hand corner there. But if you're interested in reading about Inter-Eye, there's a paper you can get off our website. We've also written a white paper around data standards and interoperability for Australia, which I think you might find interesting. So it's 15 minutes since I started, so thank you for listening, and look forward to the discussions.
Thank you, Len. And obviously that covers some very interesting information. We all know that much of the information we capture in aged care is subjective, and optimizing that's a key goal. So thanks a lot. Len will be available for Q&A after the third speaker, which we analysts. So if you have any questions, please use the Q&A panel to send through the questions, and we'll be able to ask those directly of Len at the end of the session. I'd like to introduce our next speaker, Dr. Claire Mason from CSIRO Data 61. Claire is the Principal Research Scientist at Data 61 and specializes in understanding how new technologies are affecting our workforce. To understand these impacts, Claire analyzes novel data sets to capture insight into the demand and supply of workers and skills. Claire led the delivery of the Data 61 Skills Dashboard and served on the expert panel for the Digital Transformation Skills Strategy delivered to the Australian Industry and Skills Committee in 2021. Over the course of her research career, Claire has published more than 20 peer-reviewed journal articles. Her Google Scholar H index is 18 with over 1,000 citations. And she served on the editorial board of the group and organization management for 10 years. Over to you, Claire.
Thank you, George. That was very kind of you. If I might share my screen, I want to talk today about a different angle on digital transformation in aged care. I think Len gave us a great overview of the importance of streamlining data collection and interoperability. I guess I've got to talk about another piece in the puzzle, which is ensuring that we have a workforce with the skills that are needed to work with digital technology. So we're in a situation where we have best practice use of technology changing sometimes faster than students can complete the whole qualification that they're doing. And that's especially difficult for sectors where vocational education and training is the largest provider of education to the workforce. And that's, in fact, most of Australia goes through vocational education and training. And the problem there is that accredited courses require a multi-year national consultation process before any content can be changed. So we have this situation where technology demands, along with demographic changes, global workforces becoming more highly skilled and highly connected, all these things are creating a lot of change in the way in which we work. And yet on the supply side, it's really hard to change what it is that our courses deliver. And the kinds of rapid changes that we're seeing are well illustrated by the work that the National Skills Commission has done, which demonstrates there are 25 new occupations that are commonly advertised in Australia and yet do not appear in our full list of Australian and New Zealand occupations. So, for example, in healthcare, there are new roles like respiratory therapists, nurse liaisons, and biostatisticians. And a lot of the new roles, if you look at them, are connected with use of data and technology. And that's because when we see new technologies being introduced, it's not that it usually gets rid of workers or decreases the number of jobs that are available. In actuality, it creates new ways that people can add value with the technology and the new data. And that creates new roles for people that didn't exist before. And for existing workers, it means they need to use those new technologies to deliver what they were doing before more efficiently. So what kind of skills do they need to develop? In general, we can see that in the last 5 years, our workforce has been showing increased demand for highly skilled workers, people with a bachelor's degree or higher, and declining demand for people with relatively low skills. And that's also true in aged care and healthcare, where we have, I think, 51% of the workforce have a bachelor's degree or higher, and less than 15% don't have a higher qualification beyond year 12 school. So this kind of demand for higher level skills is occurring because technology tends to automate routine rule-based tasks. And the bit that can't be automated is more complex and difficult. So we do need our workers to invest more time in becoming educated and skilled, because the work they're doing, with the simple work being automated, is harder. But if we're making a bigger investment in education and training, we need to know where that investment should be directed. What skills are needed in this technologically enabled environment? And if we look at the occupations that have been growing fastest over this period and those that haven't been growing so fast, what we actually see is the occupations that are growing fastest in this technologically enabled work environment are ones which require communication and people skills. And even though we've been hearing about science, technology, engineering, and math skills, STEM skills, a lot in the media, they're not actually growing as fast as the interpersonal skills. And there are two reasons for this. The first is that the services sector is now our largest employer. And if you're delivering services, you need to be able to communicate with people and make people understood and supported. So for healthcare workers, aged care workers, it's great news. They're highly resilient to future automation, and the skills they have are in demand. But for the employers in aged care, it's hard in that these workers have skills that everybody needs these days. And so it's quite difficult to recruit. And the other reason why these skills are in so much demand is that these are the ones that complement what the technology can do. So in general, technology can do mathematical computation much better than a human being, but it can't make another human being feel understood or empathized with or motivated in the same way as a human being can do. So that's why we're seeing communication or complementary skills becoming more important in this technologically enabled workforce. So that's the big message, is that technology doesn't require us all to become physics or programming people. In fact, those skills are showing relatively low demand. But what we need to focus on is the skills that are uniquely human and that complement the technology. So in Csiro, we've started up a collaborative intelligence future science platform. This is about artificial intelligence in particular. Some people are calling this the general purpose technology of today, comparing it with electricity in its range of applications and the transformative effect that they expect it to have on the labour market. And what we're looking at here is how you can design technology and AI in particular so that it addresses the human weaknesses, things like we have limited working memory and processing power compared to a computer, and focus on the strengths of the AI and the technology, and then allow the human to focus on their strengths. This is great news for someone like me who can't even think 2 moves ahead in a chess game, because the computer will do that. The AI will be able to process huge amounts of data, predict when I need to check in on a particular patient or what kind of medication is best practice in a given field, or even monitor security cameras with a rapidly changing environment and alert me when there's something maybe I need to check up So those weaknesses matter less, and instead I need to be able to focus on the areas of strength that only the human can provide. And that's things like being able to process input from 5 different sensors simultaneously. Computers can't do that very well. They don't have great manual dexterity, so they're going to need to do fairly programmable tasks. They're not good at novel situations and dealing with the unknowns. They're not good at complexity and nuance and understanding what makes certain behaviours unacceptable and some unacceptable, or why we value one thing over another. So this is one way of thinking about how humans and technology can work together and the potential for us to achieve optimal performance by working with technology. But what this diagram doesn't show is that this only works if the human can use the technology. And the research now suggests that there isn't an occupation in the labour market that doesn't require some level of expertise in using digital technology. There might be a few cases of specific workers, but in general, workers need digital skills. And in recognition of the importance of digital capability for future employability, the Department of Education Skills and Employment commissioned Australian Industry Standards and our team in the CSIRO to come up with a framework that would allow us to describe what those key digital capabilities are likely to be. So we were asked to look at existing digital capability frameworks and come up with one that gave us a very broad way of describing these skills that wouldn't change too frequently, that would be common across multiple occupations and common across different industry sectors. And so we ended up honing in on the European Commission's DigComp 2.0 framework. It basically says there are 5 areas in which workers need to be able to apply digital capability. So one is to finding and managing information, being able to analyze data, store data, manage data. The second one is digital technology for communication and collaboration. The third area is being able to create digital content like blog posts or films or CAD diagrams. A fourth is about protecting devices, data, ensuring that the use of technologies is done safely. And finally, you've got using digital technologies for problem solving and operating digital devices and tools. So within each of the 5 focus areas, which are exactly the same European labour market one uses, we then have 21 different digital capabilities. So these are the 5 capabilities that fall in the communication and collaboration domain. And what we've done is we've gone through all of the accredited training courses that are published on training.gov.au, and I think that's more than 5,000 qualifications, and identified every time a digital skill is being described and made sure that we can match those digital skills to one of these digital capabilities. And where we couldn't, we kind of modified the description to make it reflect the way in which digital skills are being described and delivered in the Australian labour market. And with that, we've been able to then determine what digital capabilities we are delivering through VET qualifications and which ones are not getting so much attention in our VET qualification. And if we look across all of the training packages, you can see the ones that are getting most attention are managing data and information, protecting devices, and being able to communicate digitally. Whereas we're not giving as much attention to things like understanding digital copyright and licenses or being able to identify gaps in your own digital competence and support others in learning how to use digital technology. Now, some qualification capabilities may be more important, but that's not to say it's wrong. But what's important in this analysis is that it provides a way of quickly signalling to training package owners, to educators and to workers what skills are being delivered and what are not being delivered by a different qualification. And it helps us understand where there might be gaps. So if we look across all the training packages, all the different industry sectors, if you like, vocational education and training sectors, the ones that give the best coverage of all these digital capabilities are fairly obvious. Things like graphic arts and information and communications technology, you need a lot of digital capability. What we can see is down the bottom, we have, the police one doesn't really count because they won't release all their training materials because it's confidential. But that hairdressers and beauty services are not delivering very many digital capabilities. Fewer than 5 of them are actually being represented in their training. Community service and health is sitting around average. So it's not too bad, but when you understand the potential of digital technologies to address the lack of workers in certain regions, the lack of some, the budgets constraints that people are operating under, I do think that digital capabilities need to be given greater focus in these vet qualifications. And if you actually look at job ads for one of these occupations in the community services training package, and I've focused on welfare support workers, you can see the kinds of skills that the employers are saying they want. And they're not surprising, things like disability care and first aid, patient-centered care. But you can see that there's mentoring individuals, which comes to this idea of being able to teach other people how to use things. We also have computer literacy being important, guiding others, and e-learning. So if we just start using these digital capabilities to look at what skills are being delivered and what skills are being demanded or needed by employers, we get a better sense of where there might be some gaps and what we might need to do to address the misalignment in some of the skills in our workforce workers. So I think that kind of brings me to the end of what I was going to talk about. I guess what I want to summarize with is that fundamentally, all this new technology comes down to workers needing to be able to use that technology. They don't need to be able to program it. They just need to be able to apply it appropriately to help a customer, to do things more efficiently, to add value in a new way. And then they need to focus on those skills that the technology can't do. That might be your interpersonal skills, that might be your manual dexterity, it might be your ability to deal with novel situations, because a computer program can only predict or guide decisions for context that it's been trained on. If the context hasn't appeared before, it just can't deal with it. And then to be able to use the technology, we hope we've provided a useful framework, or at least stolen from the European Commission, a useful way of thinking about what digital capability we all need to have. And that is in the ability to find information and data and store it in digital and databases, be able to analyze that data. And sorry about that. And then to be able to use that technology, let's say in video conferencing, in sharing data with others, for communication and collaboration, creating content, making sure we're using that data safely, that we're protecting the devices and the confidential information, and then being able to use it to solve problems for a client, to operate devices and tools where needed. So I hope that gives an idea of the kinds of things that we see being important in building that digital maturity on the workforce side, and joining up with the kinds of things that Len was saying in terms of how the technology can help on that other side.
Thank you, Claire. Thanks for that very comprehensive coverage of digital enablement and education. Now we'd like to go to our next speaker, who is Ms. Anne Livingston, the Executive Lead, the Aged Care Industry Information Technology Council, and has been involved in the community care sector for over 3 decades, specifically in the area of service delivery, research and development. She is committed to delivering innovative, quality and responsive community services through person-centered care, and anyone who's been involved with the council will have engaged with Anne and know the quality of the work she delivers. Over to you, Anne.
Thanks, George, and thanks for the opportunity. I've only got a couple of minutes, so I'm just going to drill deeper into some of the project work that George has spoken about earlier, and particularly talk about some of the findings and some of the, I think, the great opportunities to improve our data maturity, our systems maturity, and our workforce maturity. I'm going to particularly focus on recent work we did in clinical systems in residential aged care. And before all my colleagues in community care start to say boo, this was the first start in what should and will be applied to community care as well. So I'm going to reflect on some work that we did recently, and particularly look at the systems and the infrastructure in place, but also put an extra plug for the need to co-design our new platforms that are needed. So specifically, in 2021, the Council embarked on a body of work in conjunction with the Australian Digital Health Agency. And I think it's really fair to say our partnership with the agency is really advancing opportunities for the sector to become more digital mature, and to strategically think clearly about the pathways to achieve that. So our project in 2021 looked at 4 elements, and I'm going to briefly touch on some of the high-level findings from that project. We particularly looked at infrastructure and the external use of clinical software in residential care, those interface issues that we have with other providers, as Len mentioned, in the acute care, but as we know every day in the delivery of services with other professions, allied health, GPs and other entities. It's important for us over the last couple of years, the work that we've been doing investigating and implementing the use of My Health Record, and I'll comment just about some of the findings from this specific project, which are building on the project we're currently doing in the background, which is developing the guidelines for the use of My Health Record in aged care. And then maybe some comments about some of the future strategies and being involved in the council. So what did this current research tell us? And I'll ask Georgie, the top line of these boxes, probably nothing new. We do know, we did ask the question about the use of various technologies and what actually the technologies that are being issued or not. I guess what's important is the level of innovation here. It's probably no surprise that fax machines are still loved and cared for in aged care, but we're also seeing the emergence of more smarter technologies, but not at any scale to influence like smartwatches. We do know that there's exceptional abilities to improve the resources that we've got and the infrastructure that we've got, and to deliver technology in a better way to many of our workers at all levels. But what did it find specifically in terms of the use of clinical software? The respondents to our survey said that 93 identified that 93% of them do use a clinical system. But categorically, 5% said they don't, and there's a bit of a gap there, and perhaps they don't or do not know. But in terms of that 93 who do use clinical software, I guess our finding was pretty concerning, that 54% of them reported that their clinical software was indeed not functional, and that they reported that there were major problems in delivering on the current infrastructure that they were using. We did also ask some questions. The importance, as Dr. Mason alluded to, the importance of who's using what and what workforce levels need to be properly trained. We were surprised that some reported that volunteer personnel were using clinical software along with technical personnel. But we do also know that there's a number of positions that it's great to see that they're using the clinical software existing, including visiting allied health. But what may be of a concern to people is that we identified 284 unique platforms or systems being used. They were distributed over a number of areas, but our top 5 that they reported that interface and relate to clinical delivery are listed on the screen. There's probably not too many surprises there, but I guess in terms of making decisions of what platforms to use and procurement, 284 unique products is quite a variety to choose from. So what we did also find was that there were some key systems that we drilled down on, and we were surprised that they weren't in numbers that we expected, including medication management systems and health monitoring systems. So this report really gave us an insight about what the investment drivers have been and what the opportunities are to do further investment in really impactful technologies to improve the quality of care for older people. But what we did find is that integration was a big issue. About 50% of our respondents did highlight that there was some interface between the systems that they're using. And from that slide, some of them were using, the slide before, some of them you were using a high level of different applications. But really, we found that 50% didn't know or did report that their systems did not integrate in any way. And that was a common thread from the consultations that we had during this program of works, that people were really saying that interface is no longer going to, that we need to do more about integration of the platforms that we're using. We did also explore the barriers to adoption, and the word bubble here probably won't surprise many, but digital literacy was a key issue along with integration, and the lack of resources and the lack of time to implement and to strategically plan out the adoption of technology in organisations. We're very interested in the use of clinical software in any aged care service and its relationship to those people who visit facilities. And this, I guess this material has really informed some future work that the council is being involved in, particularly in terms of the Australian Digital Health Agency's work around transitioning of care and some of the work that we've been undertaking in the implementation of My Health Record. It's great to see that some visiting service providers external to a residential aged care facility do integrate, but this slide shows that there's great possibilities to do more. But we can do more when we have a more standardised approach to data and to record keeping. And one thing that was great concern to us through this study was the lack of uptake of My Health Record. This slide upon you is the Digital Health Agency's current stats, that My Health Record is currently being adopted in only 14% of residential aged care facilities being registered for My Health Record usage. But of that 14%, only 3% are using it. Similarly, our project late last year showed that fairly similar and dismal uptake of My Health Record, with 72% of organisations responding to our survey didn't even know if their residents use their health and have a My Health Record. And I know that our current moves to make clinical software conformant have been great and really well received by the industry. And it's concerning that the integration with My Health Record that we identified in this current project was indicated to be very lacking. But we couple all of that with other work that we've done around clinical software systems and the evidence that these platforms can actually make a significant contribution to older people and their care. And I note that Dr. Kate is on the line at the moment, who helped us, Kate Barnett, who helped us with a lot of this research. And we know that there's significant areas, and I won't go through them individually in the time that's available in today's presentation, but we have identified in all our work some really clear evidence that these systems can improve the quality of service provision and care to older people. So how do we get it right? How do we advance digital maturity in the sector? So the council has identified a number of ways forward, and we're working really collaboratively through the series of projects that George has indicated. but we see that there's great opportunities to collaborate more. The Data 61 CSIRO collaboration, we're very keen partners in that and are looking forward to that rolling out and having an impact in our sector. Alongside Professor Gray's unit at UQ, we are working on the STAR Ratings project and are hoping to also really put a spotlight on how that's going to be implemented and communicated to the sector. We do also see that there's great opportunities to embrace technology. Our Itec conference coming up in July, I hope everyone's attending because it's going to showcase really leading edge technologies that are in the sector now or about to enter the sector. And we're really advocates for co-design, both with technology developers, but with the government in terms of new decision-making around systems and processes. But we've got a couple of specific requests to be involved, and currently we're working on a range of work around standardisation and data efficiency, and we'd love you to be involved in any of that work, and I'll put the succinct email addresses. But in particular at the moment, we're advancing this work that we undertook in terms of clinical systems, and particularly drilling down at the moment of more rural and remote and isolated providers and their use of systems. So currently we're exploring the use of systems specifically within the Northern Territory. So this is a call out to providers who might be on board, who might be some of the few agencies that are providing residential aged care in the Territory, to contact us. We'd love to have some discussions with you about your approaches and what some of the best and better practice we've identified in some of our consultations in that geographical area. So George, it's my call to hand back to you and to acknowledge that Georgie in the background and myself and George as our independent chair are really keen to hear from people about their journey about digital maturity, and to showcase good examples as well as to benchmark what our current situation is and hopefully advances in digital maturity going forward. Thanks, George.
Thank you, Anne. Thank you. And that was 3 great presentations which covered very broadly the area of research and in particular looking at its relationship to workforce. We have a couple of questions starting to pop up. What I might do for the sake of brevity, so we can make sure we don't miss on the next part, is hold off those questions till the end of the second session so that we can answer them all together, because I think some of these actually do relate both to our research team and also to our providers of care. So at this stage, I'll push forward with, and we'll move for the questions. And we'll move into the Advancing and Achieving in Practice case study panel. And first of all, I'd like to start with Daniel Petman. So Daniel Petman's from Baptist Care. He's a 20-year veteran in the technology sector, having worked across numerous industries, including retail, government, education, and more recently, health and aged care. He's currently the Chief Digital Information Officer of Baptist Care, where he leads the various aspects of IT. And he's passionate about using technology in improving the care experience. I'll hand it over to you, Daniel.
Thanks, George, and thanks to everyone for coming along this afternoon. Okay, so I think I've got about 10 minutes today just to talk, I guess, from a provider perspective around, I guess, some of the considerations for digital maturity from a provider's perspective. I've been fortunate enough to be at Baptist Care in my role for over 5 years now, and it's been quite a journey from starting off at not the greatest state of digital maturity, but moving through the years to an increased state of digital maturity. And we have a couple of other providers on here today as well, which will talk about other aspects of digital maturity. But the 3 I wanted to zoom in on quickly was just the notion of strategic value, IT governance, and prioritisation of initiatives. So I remember when I started in this role, there was a little framework myself and my team at the time referred to, And I think we sort of came in about level 1 on this framework at the time. We really were a very basic IT service provider. We supported the IT in the organisation. We would deploy IT. We weren't really providing much more value than that. And over the years, we developed that into a much more mature practice. We put in underpinning infrastructure and technology that really worked. And we developed sort of a service culture in terms of understanding that everyone who used technology in the organisation needed to do their jobs. And if it wasn't working, it was a really impediment to that. So really focused on making that technology invisible to people in the organisation, just part of their day-to-day jobs. And when things did go wrong, they would get swift and helpful support. And we knew 5 years ago that we had quite a bit of transformation to do with a lot of the legacy systems we had in. So we needed to set up a project delivery capability and a change management capability. And we needed to get to the point where we really understood and combined our business's requirements with the technical requirements that were needed to deliver these systems. And so we came up with some principles about the type of systems and technology we wanted to see in 5 years' time, and started with that and started executing that journey of many system upgrades to get to that point. And I think increasingly we've been part of those larger strategic discussions with our executive, with our board around IT investment. We've been looking at the market. We've set up an internal innovation group in our organisation that has members from everyone in the organisation participating in that. And instead of really focusing on those lower tiers, we're far more focused now on leading, that change and identifying those opportunities that are going to push us forward in the next 5 years. So it is a journey. It's taken us a number of years, and certainly at the bottom of that model is, having IT culture and talent, and talent is certainly a challenge for everyone in the technology world at the moment. But it's essential to just sort of fulfill what you want to fulfill. The second item, which I think was really key for us, was just having really robust IT governance. Technology projects are complicated. They involve process, culture, new skills and capabilities, and systems and data. And you really need that engagement at all levels of the organisation, your executive, your board, and you really need a dedicated time with those groups to really understand the challenges of implementing some of these enterprise systems and the level of time, money, and change that's required to invest in them. We certainly have a lot of training for people involved in projects in our organisation. We train project sponsors in what they need to know to be sponsors of projects. We talk to them up front about what's required in these sort of governance roles, because not everyone comes naturally with sort of an IT governance skill set. And we try as far as possible to standardise the practices across our organisation with projects. And we make sure those projects include commentary on the risks of technology projects, the rollout and the performance of those projects, and the value that those projects are delivering. No one wants to roll out a technology project and not get the business outcomes at the end of that project. So that's been really key for us as well. And the last one, I think it's challenging to be an IT leader in general, but particularly challenging in the aged care sector, given the amount of transformation that has started to happen and will happen over the next few years. There's many areas an IT leader needs to worry about. I've listed a few there. Cyber is certainly a big one, as Anne mentioned before. Talent, and that's been talked about before, access to the required talent to execute a lot of these IT initiatives. And then you need to balance things like your digital customer experience, but also your digital employee experience, given the workforce challenges the sector has. Of course, there's tension around funding, and technology investments aren't usually cheap, and there's a lot of emerging tech out there as well. So to balance all these things, I think you have to really keep an eye on all the interdependencies of them. You can't execute large-scale transformation without talent. If you don't pay enough attention to cyber, then you're going to potentially have a problem that stops you in your track with all the other IT initiatives. And if you don't take the long-term view in terms of your application and enterprise architecture stack, then you'll find that you'll make expensive investments without realising the benefits at the end. So I think keeping all of these things in balance is something certainly at Baptist Care we've tried to do in the right proportion. So those are sort of my three keys. I hope that provides a bit of perspective from a provider's perspective. And I know Peter and John will provide some good thoughts as well.
Thanks, Dan. That was quite comprehensive. Covers a lot about what's happening at Baptist Care and your thoughts around how digital maturity can assist. Our next speaker is Mr. Peter Newing from Presbyterian Church of Australia, who's their CIO. Over to you, Peter.
Thank you for the opportunity to participate today. As we're sitting around the kitchen table this morning, comparing notes with the family as to what we're up to today, I mentioned I was participating in a digital maturity workshop. Their suggestion was that my worthwhile contribution to the forum is probably the fact that I'm old. But I hope that my contribution today is a little bit more substantive than that, as I work through one of the projects that we've implemented at Presbyterian Aged Care. A brief word on Presbyterian Aged Care. We are what is probably classified as a medium-sized provider in the Australian market across, if you like, the three business units or the three core businesses in aged care in Australia, which is resi, home care, and retirement villages. The project that I'd like to talk about today is a program which we call our Rack of Technology Refresh Program. So back in 2018, we recognised that, or the business recognised that we had challenges around our technology, and specifically with our ageing phone systems and our nurse call systems. There was increasing demand for customer Wi-Fi and access to the internet. And we also had very inefficient timesheeting processes for our staff. And so the solution was the introduction of 5 key technologies across all of our resi sites. And that was essentially digital telephony, next-gen, or what I called next-generation Wi-Fi. We already had some Wi-Fi capability, but it certainly wasn't available for our consumers to use. Spectrally decked phones, or wireless decked phones that integrated nurse call and the digital telephony. A new next generation nurse call system, which again integrated into our phone system and the Wi-Fi, and moving to biometric timesheeting. None of these technologies are particularly startling. None of them are what I would call leading edge in terms of what's available out on the market, but they were certainly technologies that we had yet to implement or had struggled to implement over the years in PAC. The business case for the program of work, interestingly enough, was largely not financial. So as Daniel has articulated, our business in a similar manner is adopting best practice project management and looking for robust justification for projects. However, this one was not a financial justification as it happens. The key drivers were around customer satisfaction with our services. It was also to meet the challenge of increasingly rigorous legislative requirements. I felt that particularly our nurse call systems were not helping us to achieve that. Reliability was also a key factor driven by our obsolete technology with our ageing IT environment and phones. And of course, standardisation across the platform so that we had the potential to move our staff around between our resi sites, which are largely Sydney Metro, using the same tools wherever they went. We did pilot biometric timekeeping to form our own opinion on the time savings for staff. That was one of the initiatives that did have a, if you like, a financial or at least a efficiency hours benefit that we were looking to achieve. And that was around efficiencies in the timekeeping process, the logging off and logging on, but also for the actual admin staff as well. Recipe for success. This list you could probably find on Google. If you Google searched what is it that makes programs and projects successful, my guess would be that it wouldn't be too different to what we've got up here. But that has certainly been our experience with Presbyterian. Certainly executive sponsorship that Daniel was referring to earlier was absolutely vital. The sponsor for this program was our CEO, who was a supporter from the get-go, and obviously followed that up with financial support and time. The steering committee for the program was the executive leadership team, and as we're not a large provider, as a CIO, I sit on the executive leadership team as well. So that strategic alignment and support from the executive was absolutely vital to the success of the program. Program management, I've already referred to the importance of best practice project management and program management. And that is just absolutely fundamental to being able to drive change successfully and achieve outcomes in any organisation. There are unique challenges in aged care, and one of those is around the program. So this program clearly extended over several years, and the business changed radically during that time. We had two major resi construction projects throughout the life of the project. We had significant changes to the senior leadership team, both to the executive team itself, but also to the senior leadership within our resi sites. We had many facility managers coming and going, which sadly is a common story in resi. We also had some catastrophic failures. Our aging PABXs didn't last the distance in one of our sites in particular, and so we had to move the schedule around to accommodate that. And the increasing emphasis on Wi-Fi for residents just couldn't wait for the timeframes that we had laid out. So one of the cores, I think, to the success of the project or the program was the ability of the IT team to listen to what the business is telling us about their changing priorities, and to flex with the business as their needs changed. And so the program that we originally published, our actual execution didn't look an awful lot like what we had originally thought. We achieved the outcome, but in a different time frame and in a different order than we had originally anticipated, simply because we needed to move with the business rather than simply bloody-mindedly thumping technology because we were meeting some sort of project timeline we'd published 12 months earlier. The third point is around proven technology and partners. So the technology solutions that we implemented were certainly proven in the market and even proven within our business. So, for example, our nurse call system that we ended up standardising on had been implemented in one of our residential aged care sites, and we were quite happy with the functionality and the outcome. And so I think one of the ingredients of success for us was that we didn't try to win design awards. We didn't try to be on the bleeding edge. We simply went with what we knew would work and standardised on it and rolled it out. And that is true too also for our partners. So, for example, with our Wi-Fi solution, we did not look for best practice Wi-Fi out on the market. We looked for best practice Wi-Fi within the suite of IT partners that we'd already engaged and trusted and knew us. And so I think that was a major ingredient in success of the technical solution, also hitting the timeframes we were after. Business change management. It was interesting to hear the presentation earlier today about digital skills and literacy. And anyone who's worked in aged care knows that that is a major impediment to making change, and particularly into introducing new technology. And so we had a major emphasis on business change management. The IT team were heavily involved in going out to site, hand-holding our staff. The nature of shift work staff means that training sessions, particularly, and our preference was to do them face-to-face as pre-COVID, and we could do it face-to-face. And so the IT staff were engaged at all sorts of hours in order to be present when a shift changes and so on, to make sure that we'd caught everyone in the change. And interestingly, the business change management doesn't stop when the project stops. One of the challenges that we're experiencing now, a couple of years down the track, since implementing these technologies, is that we need to go back and constantly retrain and constantly remind new facility managers, for example, that there is functionality that is available for them to use. They may not have used another provider, but it is available for them to use here. And so they should be doing that and encouraging their staff to do that. So business change management and training, absolutely critical, not just for the project timeframe, but for the ongoing benefits realisation post-project. And finally, stakeholder management. And certainly I've talked about the stakeholders being the executive team, clearly our staff, our major stakeholders in terms of implementing the change. Perhaps one of the stakeholder groups that we traditionally don't put as much effort into is actually our IT partners. We, being a smaller provider and heavily outsourced, we rely very, very heavily on our IT partners coming to the party when we need them to. And so one of the actions that we undertook quite proactively was to invite all of the IT partners in together in to meet with us, to work through where we're headed as a business in terms of our business strategy, meet with the CEO, walk through the IT strategy, what are we trying to achieve in IT, and then to get into detail about the IT program of work, particularly this one, which involves multiple vendors talking to each other and cooperating well. And so part of particularly the IT team's focus was on engaging those IT partners to make sure that was all being done well. So that concludes my presentation, and thank you for giving me a few minutes to talk about our experience with our Tech Refresh program.
Thanks, Peter. And again, quite comprehensive, and some of those recommendations there, I think definitely be shared across the board. Our next speaker is Mr. John Sutherland from Hammond Care. So John's the recently appointed CIO of Hammond Care, but prior to that, he has had many years experience as the CIO of Ramsay Healthcare, which is one of the largest is the largest private healthcare provider in Australia. And I'm sure he'll be able to share some knowledge across his journey from as a CIO in acute care and now joining us over in aged care. Over to you, John.
Thanks, George. Good afternoon, everyone. Okay, well, good afternoon, everyone. And just a call out for the great work that George's team does at the Technology Council. It's fantastic research, and it's presented in a way that is readily accessible and usable. And I'm certainly using that with great enthusiasm here at Hammond Care. As George indicated in my introduction, I'm fairly new to aged care. Been with Hammond Care for a few months now, but about 20 of my 30 years experience is in healthcare. So I thought my contribution today could be to talk about some kind of general themes in aged care and in healthcare more broadly, and looking forward to any questions on those topics. So just to kind of kick off with, I think back to the basics, a couple of things here, and I quite like this cartoon here. And you know, technology, we have a love-hate relationship with technology. I think we do in a workplace, in a professional sense, in a research sense, and from a consumer perspective. And of course, the challenge is that technology does one or two things. It either kind of enhances our lives, or it improves health outcomes, or it kind of detracts. And this is, I think, a kind of a great reminder that it's very easy that if we kind of have some missteps, that technology gets between caregiving and care receiving. And that's something that we need to be very alert and alive to. So it would be fantastic to see that more detail on that latest research at the upcoming Technology Council conference. The other one that I think we're at risk of making a mistake over, and that is the kind of the inflationary cost that technology has in healthcare outcomes. Now, this data is about 10 years old, but I think it's still really relevant today. It's showing on the left-hand side, or the vertical axis, health outcomes. So for poor health outcomes, at the bottom left, and then the better health outcomes are at the top of the vertical axes. And then across the bottom are the per capita investment in US dollars. So what this table tells you here is that there's a sweet spot in the top left-hand corner of the chart where the investment in healthcare per capita at a country level gives the best healthcare outcomes for the citizens, the constituents. But then spending above and beyond that, really, you get very little return or incremental return in the healthcare investment equation. And our friends in the US there, right on the right-hand side there, at kind of 10 years ago, $9,000 to $10,000 per capita, but with healthcare outcomes that were worse than countries like Singapore and others, spending 20 to 30% per capita on their citizens. So salient, I think, chart, and as it relates to the work that we're doing in aged care, an encouragement to really be making very careful investments in technology, because it is inflationary. So we've got to really be very wise about where we spend our investment. So for the practitioners on the call, I know we've got providers and practitioners and vendors and researchers and perhaps some from government. Why do we turn up each day? Well, a bit of a call out for the providers here, and if you are a student of history, you would understand that healthcare really has been driven by a lot of the faith-based organisations, and we've got 3 of them represented on the call here today. But we really turn up to help focus on our clients, patients, residents, and aged care sense. And in this year, in 2022, Hammond Care celebrates its 90th anniversary. So it's the same age as the Harbour Bridge, so I remember that. And what we're really here to do is to write the next chapter in the care that we're providing to those which we're custodians of. Through the role of technology. And on that book there, Dr. Meredith Lake is a historian and wrote History of Hammond Care. And what we hope to do, and as all the providers, as Peter and Daniel have said, is really to help write the next chapter in that history. And that chapter will no doubt show far greater prominence to the role that technology has played in helping those in our care. So that's why we turn up each day. Now, when we kind of step back, and I, coming from hospitals, as George indicated, across to aged care, I was being quite shocked really at the state of the sector, and that was really shown in great detail through the Royal Commission's reporting. And to use the words from the Commissioner, that the sector, when it comes to technology or digitisation, as they coined it here, is really in the dark ages. But it is what it is, and of course, the great opportunity is to really embrace that challenge and to move forward and bring the sector into the 21st century. Now, from a practitioner's perspective, when I think about what I need to do as CIO of an organisation in helping to make change, I think about it in terms of 2 things, and I hope this might resonate to some extent with those for joining us on the call today. So one is around mission, and the other one is agency. We're familiar with what the term mission means. Agency, if you're not familiar with the term, it's more common in the US. It's really about being empowered to act or make change. So mission and agency are 2 concepts that are interrelated. If you have a mission but without agency, well, that's kind of not a good place to be in, because really you're unable to make change. And similarly, having agency, having support, as Peter and Daniel talked about, there might be great sponsorship from the CEO or support from the board or resources, but without having clarity of mission and where we need to be heading and the changes that we need to make and how we go about those changes, then we're kind of in the same position of having a mission without agency. So to my mind, these things very much go hand in hand. that's a bit perhaps a bit academic, ephemeral. If we bring it back to something a little more pragmatic now, Hammond Care and its 90-year history. Our 3-year corporate plan we've coined Next Chapter. So we can kind of continuing to write the history of the organisation. And the way that I'm approaching the role as a new CIO to Hammond Care is to really engage with the organisation, the board, the CEO, Mike Baird, for those of you who know the name, is the CEO of Hammond Care, and doing great work in the public advocacy place for the sector. The executive team and throughout the organisation in helping them understand the opportunity that technology can provide for the organisation. And so when I kind of approach that, I've pulled together this picture here. Now there's a lot of detail on here, and your eyes are probably being drawn to the table there, just to give you a bit of an idea how to read this. In our next chapter, our corporate plan, we have 5 themes, and you can see those in each of the rows there. Best people, highly valued, data-driven, because we have a large research group within Hammond Care. Operational excellence, shaping the sector, so that's really about playing a role with the other providers and helping shape the sector and influence government policy, and then the operating model. Now, those things are not particularly unique to Hammond Care. But really, I guess the main point I wanted to say here in terms of how we're engaging in the conversation within the organisation is that subtitle here on the slide. And I've emphasised a couple of words here that I'd just like to tease out for a moment. The first is that I think we're in error if we think that the conversation is just about technology. You know, in the past, when systems were kind of nascent and fairly basic and rudimentary, they were kind of standalone systems that were tightly boundaried in terms of what they could do. They couldn't talk to each other and so on and so forth. We come forward to where we are in 2022. Of course, we have this concept of platform and platform thinking and APIs and data integration, and of course the rise of the cloud and all the fantastic services and capabilities that are available by the vendor community, which we can tap into. So the first point I would like to emphasise here is that when having the conversation with the organisation, one must keep the concept of the business's operating model and the technology agenda together. And the organisation may try to kind of want to pull those apart, but our role as CIOs and others that are on the practitioner side and the provider side really need to keep that conversation together. And the second piece really is emphasised there around the importance of the consultative process and it being integrated, and integrated both in terms of the business model, the funding, the project office if the organisation has a PMO, and sequencing of change and so on and so forth. So that hopefully paints a little bit of a picture about how I'm looking at approaching the role in Hammond Care. Now, the projects on the right-hand side of the table there, they're indicative, and just this is really for illustrative purposes. Of course, there are many more. And of course, it's a great conversation starter to have in an organisation, and you know where the organisation stands today and where it needs to be, and to what extent are those 5 themes reliant on technology in the future. And the last point that I'd like to make is the importance of communication. And Dr. Mason was touching on this about the importance of communication skills. And there's a saying that the soft stuff is the hard stuff. And what that means is that, you know, as providers and vendors and technologists, we've got, you know, good technology skills. You know, we might be engineers or trained in computer science and so on and so forth. They're kind of the hard skills, but the soft skills are really critical to have the conversation, and soft skills around how we communicate. And I would encourage all of us working across the sector, that unless we can, that we first of all need to recognise the importance of communicating effectively. This is an example of some work I did in my prior role at Ramsay Healthcare. It's available on their website if you go looking for a 60 or so page annual technology report, really looking at all the great things we were doing in the technology field. And I would just encourage everyone that I think it's really worth the investment of time and energy in communicating with your stakeholders, whether they be your exec team or your frontline staff, or more broadly across the industry. So I hope those kind of comments are helpful, and thanks very much for your attention.
Thank you very much, John. Thanks a lot for that. And that was, again, another great presentation, which gives us a deeper understanding of the issues and challenges being faced at the provider level, and balancing those with the work being done by our researchers, looking at how technology can help improve the delivery of care. Look, we've got a couple of questions. We'll go through those quickly before we go to our next speaker. Question here for the provider panel. So one of the major recommendations of the Royal Commission was to invest in technologies such as telehealth, clinical software, medications management, and the My Health record. Have the different providers taken this on board, or are other issues like workforce seen as more important? And I guess this sort of relates to the fact that within the Royal Commission, there was 148 recommendations, and whilst a couple of those were technology, the vast majority of them related to other aspects of aged care. How does that affect you guys as aged care provider CIOs or heads of technology? And I'll start off with Daniel. We'll work our way through there.
Certainly from Baptist Care's perspective, we've certainly made investments in most of those areas, telehealth, clinical and medications management. I think probably goes back to my point before about balancing all of these priorities. You can't do them all at the same time. You've got to pick at times what is most important. For us, workforce is a critical issue, and we've also put quite a bit of investment in terms of looking at our human resources systems, our onboarding systems, measuring our employee experience and engagement, and that's an area which is very important to us. So it is, yeah, it's challenging to do these all at the same time. You have to sort of stagger them over a period of time.
Thanks. Peter, like to comment on that?
Sure. So yes, it's a balancing act. So Presbyterian Aged Care, we have most definitely invested in clinical software and medication management software. We haven't invested a lot of time in the My Health record yet, and we have been doing a little bit of telehealth. However, it's interesting. We have invested in workforce a few years ago on the back of the Aged Care Royal Commission and the general move in the aged care standards towards focusing on the customer. We were actually keen with the business development manager, put forward a proposal to start looking at a CRM solution. And the actual executive management team said no. They actually said we think our greater need is in our people, in our staff, and so let's talk about HCM rather than CRM. And so they changed the priority for us. So for us, the question is a good question, because we have seen in our experience that investing in workforce technologies, it's just a fundamental we need to get right if we are to deliver the quality of care to our customers that we would like to. So the answer is it's a balancing act for us. Yeah.
Thanks, Peter. And John, any comments on that?
Look, similar comments to Peter and Daniel. I'll just add that my understanding that Hammondcare had underinvested, I guess, in some of the enabling functions that, whether they be HR, marketing, technology, in recent years, because the focus of the investment had been at the front line, which is absolutely fantastic. But of course, at some point you have the recognition that if you don't kind of bolster the foundations, then you can't keep adding kind of stories. If you think about a building, a metaphor of a building, and So I think the recommendations from the Royal Commission have been helpful to crystallise that understanding. So we're probably playing catch up there, and certainly we've got a fair way to go. It's interesting that government kind of mandates without kind of support for some of these systems can be quite costly. It does create more stress in a sector that is under significant stress, particularly given the workforce issues that are quite prominent and have really become part of the battleground for the government and opposition. So it will be interesting, and I think it's great. I think we're all probably very happy that it is such a hot topic, and that there is that civic debate that's happening now at the moment.
I have to admit, it is exciting when you watch both of the major parties, actually, even the minor parties, and watch the news every day. And aged care has come up a number of times as a major topic in this election. So it does validate some of our work over the last decade or so. Anne and Len, and unfortunately Claire could no longer be with us. She had to rush off, but the question would probably relate to her as well. Taking that same question, putting a slightly different slant on it, looking at the 148 recommendations, half a dozen or so were very technology specific. But if you look at the others, do they have a technology basis behind them where technology can help them in improving workforce education, in providing better literacy within the organization? Things like better control of the funding models and how we understand how funding moves across the sector. Any comments from either of you on how technology can affect those other recommendations? And I'll start with you, Anne, because I notice you're not on mute.
I was hoping you'd start with Len on that one, George. Look, I think a contemporary aged care provider needs to underpin all their operations. They should apply a lens of technology and innovation to all of them. And I think just, at a higher level, really consumer-centric, consumer-controlled, and tailor-made and responsive services must have technology as a key component. So I think all the recommendations really warrant a lens of both innovation in practice and how technology can enable that innovation.
Thanks. And over to you, Len, and I'd particularly like to get the focus. I remember, you worked at Royal Princess Alexandra Hospital, which was the first public level 6 MRAM hospital in Australia. So, from your experience with the digitization in the acute space, do you see that same sort of learnings that the technology can affect the whole aspect of care, not just the technical aspects of care? Short, simple question.
Big question, yes. Obvious. I mean, I think we all understand that better technology permeates everything we do, and that involves care delivery, administration, and the like. Maybe I could say something about telehealth, since that was mentioned, just so we don't get too general. So yeah, there's the challenges with telehealth are, one, awareness that there's some value in engaging outsiders. There's infrastructure requirements in terms of equipment, bandwidth, all those things. There's a people thing, though, in terms of, the third thing that's really important is availability of background information. And medical practice, and I think this probably applies to allied health as well, usually referrals to outside specialists are something a little better than do the needful. Not much in the way of background information, perhaps a list of drugs and a list of diagnoses, but not much understanding of what the human being is that's behind all of that. So you end up spending an awful amount of time just colouring in the background of the person. All of that information resides in many software systems in the facility, but it's not able to be accessed externally, and it's not presented in a format that enables it to be digested quickly. The other piece, moving to the people side of it, is hosting and ingesting the external advice and operationalizing it when you give advice. you have to have sufficiently trained and staff who've got the time to kind of engage in the dialogue with the external expert and then to operationalize the recommendations. And that's probably the biggest bugbear of the lot. It's having that outward-facing person to interact with the expertise that sits outside. And this is medical, it's allied health specialties, wound care, all these kind of things are. So there's a whole set, layer, suite of things. Some of them are very technology oriented and others are about people training and expectations. That we're making progress. Things are a little bit better over time, just slowly, but I wouldn't say there's been an explosion of development, to what is actually, we could do an awful lot more right now with all of those pieces kind of fixed. It's not like we're waiting for the solution to be invented. It's more about getting organised properly. Yeah, so that's just one example of that I know pretty well.
Yeah. I think it does demonstrate that one thing we can do in aged care is take advantage of the learnings in other sectors, in particular healthcare over the years, and leverage some of those learnings. And telehealth's a great example that we saw a flux of activity as a result of COVID, and we saw that drop back down. So learnings from the other organisations, and I refer back to Len's work with the Centre for Online Health, which has been a world leader in this space. We've got a couple of questions about My Health Record, but rather than answer those now, I might segue to our next speaker, which is Mr. Ben Cohn from the Australian Digital Health Agency. So Ben is the Acting Director for the Education and Adoption Team at the Australian Digital Health Agency and delivers health education to healthcare providers and consumers. He's previously worked as a consultant at EY's Digital Health Team and has many years experience in PHNs, Medicare locals and divisions of general practice. And as the Digital Health Agency is responsible for My Health Record, maybe we can bundle any questions we have around My Health Record and education after Ben's talk. So over to you, Ben.
Great, thank you very much. And hopefully you can see my screen, George. That's all visible.
It's all there.
Fantastic, thank you very much. So hi everyone, as George said, my name's Ben Cohn and I'm the Acting Director for the Education and Adoption Team at the Australian Digital Health Agency. Excuse me, I'm going to briefly take you through some of the activities that the agency is doing for both provider and consumer digital health literacy, and obviously with a focus on aged care. So I've just got a few dramas here with where the screen's behaving, but that's all right. So what are we doing in the provider space to increase digital health literacy? Well, the agency are aiming to increase the adoption of My Health Record, and this has been discussed quite a bit during this, during these presentations today. So it's very topical, and we've established the aged care program to drive this adoption and interaction with My Health Record. Look, from a number of sources, we know this comes with its challenges, and we're prepared to meet those challenges with providing education within this sector. And these sources include the National Aged Care Workforce Census, the data from the Australian Institute of Health and Welfare, the Australian Government's Matter of Care, Aged Care Workforce Strategy, and also obviously the final report for the Royal Commission itself. Now, we know there are a lot of resourcing and capacity constraints within this sector. We're aware there may be a degree of reform fatigue, and whether that's through adopting the recommendations of the Royal Commission or through changes to funding or assessment models. These competing priorities may affect the capacity and the appetite for training in a new system. And look, Anne touched on some of the challenges with clinical software in aged care, and we're aware that many of the aged care clinical and medication management systems aren't integrated at the moment with My Health Record. And also showed the limited uptake of My Health Record in RACFs, with 14% being registered and fewer using. And just to give you some idea, this compares with 99% of general practices and pharmacies that are connected with My Health Record, and the same number actually using the system. So we know obviously that there's a considerable gap here. So to help address this, and look, many of you will be aware on the call today, the agency have undertaken an aged care industry offer. And phase one of this offer includes and isn't limited to the ability to view My Health Record for a subject of care, which will be a huge advantage for those systems that are out there, and also the uploading and downloading of advanced care planning directives. So the uploading of advanced care plans through aged care systems will really help increase the number of these documents that are available within My Health Record. Additionally, our team at the agency deliver fortnightly webinars for clinicians who provide care to residents. The sessions are specifically aimed at general practitioners, pharmacists, and allied health, and they cover an overview of My Health Record, what documents are available, and which ones are particularly relevant for aged care. We also talk about the benefits of My Health Record, and there's a particular focus on the transition of care. And we also look at the privacy and consumer controls. The sessions are interactive, so really encourage participants to ask questions and be engaged in the sessions, and a case study is used to show how My Health Record can be used to improve the care of people in aged care. So again, really encourage everyone, to reach out to us if you're interested in any of these education opportunities that I'll be talking about today, and we're more than happy to provide the details of those. In addition, the agency convenes a monthly aged care working group with the PHNs. So this is largely focused on, on My Health Record in RACFs, and the PHNs share information on topics such as digital literacy and readiness, technology barriers, and we've certainly spoken about some of those today, software readiness and usability, and other potential barriers affecting RACFs in digital health readiness. Look at recent examples where a group had a vendor who had offered to demonstrate their enhanced My Health Record functionality in their product. Initially, they reached out to one of the PHNs, but instead of presenting to them alone, the invitation was then extended to present to the PHN working group at the upcoming meeting. So again, if you have any information that you'd like to share with PHNs, please reach out and we can assist with, getting that information out there. Other uses for the group was to share success stories and identify champions, obviously very important within the industry. Look, and our team has 3 phases of education. We've got awareness, engagement, and adoption, and we recognise that we're more at the awareness phase for providers for My Health Record in aged care. And at this phase, we're really just trying to sort of increase awareness of My Health Record and put across some of the benefits for My Health Record in the sector. Finally, from a provider perspective, we're developing an e-learning module that will be targeted to staff working in the aged care sector. And the module will cover an introduction to My Health Record and the documents that are available, the potential benefits of and use of in aged care, and also really importantly, privacy and security. So as you can see, there's a lot of activity happening in the healthcare provider space around aged care to improve that digital health literacy. So what about consumer digital health literacy, and what are we doing with consumers? We're currently rolling out phase 2 of the Consumer Digital Health Literacy Program. Now, look, during phase 1 of the program, the agency worked with 3 education delivery partners to establish and test different methodologies and delivery mechanisms. So we worked with the Good Things Foundation, and established the Health My Way, which emphasised that grassroots community groups who deliver the program. We worked the Australian Library and Information Association, ALIA, and that involved train the trainer sessions with library staff across Australia, which then cascaded down to events in libraries. And we work with Cultural Perspectives, who implemented an education pilot in Victoria, which focused on those 13 culturally and linguistically diverse communities. And we had approximately 14,000 people attend those grassroots events and education sessions. And there was also online forums and train the trainer activities during phase 1. So we're now in phase 2, and the agency have developed consumer digital health literacy modules for My Health Record. Again, these will be rolled out through Good Things Foundation, and they'll be working as well with ALIA. And they include things like instructional videos on how you can actually access various components of your My Health Record, and takes you through how to access and get to the information that consumers require. It also talks about some of the benefits, and there's other videos available there, showing how consumers can benefit from using their own My Health Record. So let's give you a bit more detail about the Consumer Digital Health Literacy Project. The initial modules cover the topics that are listed there on the right of the screen, and these will be expanded during the rollout to also include topics such as electronic prescriptions. But initially they'll cover an introduction to My Health Record, privacy, security and awareness, immunisation information, accessing clinical documents, adding personal information, and medicines information. And the idea there is the community groups will be able to focus on the modules that are of interest to their cohort. And they don't have to necessarily go through the entire list of those modules. They may choose to focus on specific topics that are of interest to the groups that they represent. Now, really importantly, as well as we're actually looking at, there'll be a tailoring of those modules for various groups, and that'll be the next step in this rollout. And the first cab off the rank for that tailoring will actually be for aged care. So what this will be customizing the content and the imagery of the modules, and so that it's specific for older Australians and also meet the needs of various subgroups, including carers of older Australians, older Aboriginal and Torres Strait Islander people, older cold people, LGBTI elders, and rural and remote older Australians, and also people living with dementia, disability, mental ill health, and possibly even chronic conditions. Okay, look, there's a very brief presentation, but hopefully that's given you a good idea of what the agency is doing around that consumer and provider side for digital health literacy. And I'd like to hand now back to George.
Thank you very much, Ben. And I think that answers some of the questions we had about adoption of technology. We do have a question here about if anyone can understand the difficulties we've had in the adoption of My Health Record over the years in aged care, keeping in mind that it was one of the early topics. Look, having been involved in that across probably the beginning of the day, I'd say one of the major issues obviously was just the digital maturity of the sector, and I think that's something we're focusing on today. That when we first introduced My Health Record and asked aged care to be involved in it, most aged care providers didn't have any computerized systems or very primitive IT systems in place, nor did they actually have the personnel to implement a lot of that stuff. So we're finding now with the iteration of the new program office within the agency and with the improvements in the software and the recent offer to the software vendors to integrate My Health Record into their conformant applications, that we expect to see significant differences there. We do have a question around the use of the conformant software to view My Health Record or actually add information directly into My Health Record. And Ben, you may be in a position to respond to that, but if not, I'm sure Anne, one of the other team will be.
Absolutely. Yeah, look, and obviously that's obviously what that that industry offer is really targeting is making sure that we have more of those software products that are accessible to that can actually then view My Health Record. But really importantly is also that ability to be able to upload information to My Health Record. And I mentioned the being able to upload advanced care planning documents as part of the actual software itself. So it's at the moment it's really consumers that are in there uploading their own advanced care planning documents, but this will allow the aged care organisations to actually upload on behalf of their consumers, which would be very valuable. And the other thing the agency is working on is the aged care sort of transfer summary document as well. So I don't have a lot of details on that at the moment. That's still being worked through, but that will obviously really help increase that communication between aged care facilities and hospitals for that very important transition of care.
Yeah, as I said, one of my roles is co-chair of the Digital Aged Care Advisory Group within the Australian Digital Health Agency. And just yesterday, we actually had quite a detailed meeting about those specific topics. So it really is a watch this space play, in that it's an evolving journey. And as we saw, and having those of us who experienced its use in acute care, that it was a staged process, and it was we did often reach tipping points where we just found that once the functionality hit a certain point, we had asymptotic rises in utilization. And I think John Sutherland may be able to comment on this. My Health Record use in acute care hospitals, in private care hospitals. Do you have any comments about how that was utilized in the acute care space, and any learnings we can take from that into the aged care space?
Yes, George, the uptake was very high. The uptake was very high, particularly at sort of across the privates. There are a number of anecdotes that the agency certainly was using at the time about the importance, particularly in ED presentations, where the records were very helpful. Lessons for the aged care sector. I think when the My Health Record was rolled out across the jurisdictions and the private sector, there was to some extent support provided by the agency, and that certainly helped with the uptake. And I don't know whether or not the agency is looking to provide some level of support to help the aged care providers come on board, given that there are a huge number of them compared to the kind of hospital providers. I can't kind of see they're getting good uptake without some level of support.
I can probably comment on that from my role within Digital Aged Care Advisory Group, in that obviously education is a significant part of it, but also once these offers go through, actual support, and I know Anne and her team are working with the agency on providing guidelines for registration initially, and then implementation of My Health Record. But I might ask Anne. Anne, you've been actively involved in the development of those guidelines. How do you see the support that's coming through for aged care providers in adopting My Health Record, and how do we make that go along faster if possible?
Yeah, thanks, George. The guidelines that we're developing are nearly there. We've got a target to produce those guidelines by the 30th of June this year. We've extensively consulted industry on the development of those guidelines. It's very fair to say that I think there's an appetite in the sector to deliver and to uptake My Health Record. I guess some of the early first round, there were some champions, and they did great strides to look at the possibilities that My Health Record would provide. I guess what was missing was the interaction with the whole ecosystem around an older person, and some of those frustrations have been really investigated and reviewed in our work, and we hope that the guidelines will significantly contribute to a better uptake of the use of My Health Record. I guess in terms of John's remark, it's a crowded space for providers with all the reforms. It would be remiss of me to say that we don't have a fatigued sector. This is one of many reforms that are coming through in the next 6 to 12 months. Providers are also faced with challenges about investing in all those reforms. But I know, George, we're working very collaboratively with this Digital Health Agency to ensure that the voice of providers and any barriers are identified and communicated and resolved. I guess that's the issue that we all want to work towards, getting better outcomes for older Australians at the end of the day, and working collaboratively to get in place whatever's needed to ensure that that happens.
Thanks, Anne.
George, can I just make a comment too, just about
Sure.
education? You touched on that before, and look, obviously the agency, like you mentioned, does offer education around My Health Record and also other digital health technologies. Look, we're more than happy, our team, so to provide that education. It's obviously free. So if any people out there are interested in getting My Health Record, for their particular organisations, please reach out to us, and we'd love to sort of engage with you and provide that education to your organisations and your staff.
Fantastic. We are running out of time. There is a question here for Len Gray around allied health and defining mobility issues, but I might take that offline and get Len to speak directly to Louise Blatchford about that. First of all, I'd like to thank everyone for attending. The attendees, you will be getting an evaluation survey by email shortly, so we appreciate if you could fill that in. Findings from the education session and case studies will formulate a report for the Australian Digital Health Agency, and we will be running another forum on the 10th of May, looking at quality digitally enabled care. So I do invite you to prepare yourselves to attend that event. This information, like I said, it's an evolving space. We're seeing that the aged care is coming into this digital space on the back of both the pandemic and the Royal Commission, and we have lots of real opportunity for us to take a giant leap forward in its utilisation. And on that note, I will highlight, and if you go to the next slide for me, Georgie, that in July 12th and 13th at Rosehill Gardens Racecourse, Sydney, we will be running Itec 2022. Those of you who are fortunate to have attended the last Itec in March 2020, it was probably the last live event you attended before we went into lockdown. We're looking forward to a good turn up and a very robust discussion around this and other activities relating to digital aged care. Amanda Catamol from the Digital Health Agency, Australian Digital Health Agency, is one of our keynote speakers. The Australian Digital Health Agency will have a significant presence there. We will be discussing a number of topics. So I do invite you to pop this into your diaries now, and registrations will be opening very shortly, and invite you to join us at that event. And finally, Anne and I and Georgie, who's in the background, who's been does most of the work here, can be contacted through these various emails and phone numbers. We're really keen to ensure that this discussion continues on forward. We invite you to attend our 10th of May session. We invite you to join our LinkedIn group to keep the discussion going forward. And we thank you for your patience. And I note that I'm finishing spot on time, which is one of my key deliverables. So thank you again for a great session. Thank you to our speakers for some great insights into both the research and the practical aspects of the delivery of aged care. Thank you to the Digital Health Agency for the support in these programs. And in particular, we look forward to a day when my health record is seen as an exemplar around the world of how shared health records can improve quality, safety, and efficiency of care. And on that note, I'd like to say thank you again, goodbye, see you again, and please keep in touch with us by email, and make sure to join our LinkedIn group to be involved in the active discussions going forward. All the best.